All right, let's go through I'll go through the first bit very quickly, so try and make up time. Sorry about that, but as luck would have it, we had a lot of trees down up here, and our internet just went off just as I got started. So I'm on my phone now. I'm going to talk today about online health promotion and supporting a healthy brain age, the lessons we've learned over the last 25 years, really. I want to declare some conflicts of interest here. The McGill Comprehensive Health Improvement Program is a registered not-for-profit since 1995. The Healthy Brain Age risk model was supported by a Healthy Brains for Healthy Lives program, which provided access to the UK Biobank data. And getting older daily with the health I'm getting older daily with the health complications to prove it. And that's just the way it is. Nadia, if you click on this video, I just wanted to quickly give you a sense of where we're going with this. And the question is, why is an MUHC internist posting videos on YouTube? Just click on the video, please.
Yeah, that's not working.
Okay, forget it. We'll move. If you're not doing full screen, it won't work. There you go. Not important. Let's move on if we can't work it out. So let's talk about learning objectives. Why should we avoid the biological effects of aging? This is data up until, next slide, please. This is data from Quebec up until February of 2022. And what it shows you is, relatively speaking, Canada and Quebec weren't doing all that badly during the pandemic in terms of total mortality. Relative to lots of other countries, our numbers were actually pretty good. And here's Canada down here. However, next slide, please. The story with the elderly was a completely different issue. This is looking at a comparison of all COVID-19 deaths that have occurred among home care residents since June 26th of 2020 and going up to right past October 2020. These are basically 3 waves. This is Canada. Shows you in the first wave of the pandemic, we were without question the worst country in the world. 80% of the cases of COVID deaths were among those in long-term residences. By the second wave, we were still doing terrible. The third wave, things improved, but the fact of the matter is, after up until the present, we've had close to 80% of all COVID mortality in our nursing homes. There's a couple of reasons one could guess that might be that are responsible for that. And you have to go back before the pandemic got started to understand this. To start with, our nurses' aides, orderlies, next slide, please, Nadia. I've got to remember to ask. Our nurses' aides, orderlies, and patient service associates were some of the worst paid in the world, and in Quebec, some of the worst paid in the country. This is what we were paying them back in first quarter 2020. By the fourth quarter, we recognized they needed about a 20% increase in their salaries. But even now, Quebec still lags behind the other provinces. And frankly, you know, 20, 23 bucks an hour to be doing nursing home care, when you think of what's involved, this is really tough. And one of the problems during the pandemic was because so many of these people were hired on a part-time basis, they were running from one nursing home to the other. Now, British Columbia recognized this early on, and Dr. Henry was quick to assure nursing home workers that they would get a full salary, but they could not move between nursing homes. We were never able to do that in Quebec. We just didn't have the staff. Next slide, please. This gives you a sense of where we ranked before the pandemic. The little bar here is 2011, and the little triangle is 2019. And when you look at the low numbers of career carers relative to the population age 65 and over in most countries, here's Canada. We're way down here. We were down there in 2011, and we dropped even further by 2019. This is just before the pandemic hit us. It's not that we let workers go, it's that the population started aging, and the fact of the matter is we have more and more elderly individuals, and we just haven't kept up with hiring. Next slide, please. It's not just the question of our nursing homes. Our emergency rooms are also flirting with danger to paraphrase Aaron Durfel, who published this article in the Gazette actually just a couple of weeks ago. New stats showing an alarming spike in emergency room mortality with lengths of stay that are by far the highest of any province. Quebec's average length of ER stay is high too. Just last month in the Montreal area, some ERs report average lengths of stays for patients on stretchers of more than 30 hours. Now, you'd say, all right, this is the result of the pandemic. That's why we're doing so badly. Things will get better. But this is another article from the Montreal Gazette that has nothing to do with Aaron Durfel, who we often blame for being so negative about healthcare in our province and to the MUHC. And this is an article from actually 2016, where Robert Salois, who was then the Commissioner of Health and Welfare, noted that Quebec had the worst emergency room wait times in the country. This was the data he was looking back in 2016, and you can see that Quebec was a major outlier. Unfortunately, after he published that article, Salois retired, and the government got rid of the independent watchdog agency. They basically folded the Commissioner of Health and Social Services into the government. The good news is they're still doing really good work. But as Salois said, this organization must remain, and we can't be efficient without measuring and comparing healthcare. Just a couple more slides on this issue, and then we'll try and turn the narrative into something a little more positive. This is a CD Howe Institute report from December 2021, pointing out that COVID exposed the inadequacies of existing conditions in seniors' care. Going forward, will require a significant infrastructure upgrade and expansion, plus increasing staffing levels to manage the aging population. And it's this baby boomer tsunami that's coming along that's really the major issue. One estimate projects that the spending on institutional care would have to increase from $28 billion in 2018 to $135 billion by 2041. In other words, a 3 to 4-fold increase in the next 20 years. So as bad as, and let's be honest with ourselves, this isn't going to happen. So as bad as things are right now, realistically, we can only expect they're going to get worse. Next slide, please. Final slide on the elderly. This is no joke, but the future does not look great. This is from laughtodeath.com. The article was, "Put the elderly in prison. We should place the elderly in prisons because they'll get a shower every day, video surveillance in case of problems, 3 meals a day, access to a library, computer, TV, gym, doctors on site, and free medication if needed. Put criminals in nursing homes and they'll get cold meals, lights off at 7 p.m., 2 showers a week, live in a smaller room, and pay rent at $4,000 a month. It's pretty sad that we treat prisoners better than the elderly." Let's move on to our second learning objective. How can we maintain our health, our independence, and quality of life in the absence of strong clinical trial data? And I want to emphasize this point. Unfortunately, the evidence base for maintaining our health is always going to be limited. It's simply the nature of the beast. Running big randomized clinical trials to prove that we can maintain our health and independence, stay out of a nursing home, is not going to be easy. Next slide, please. This is a nice article that came out actually nearly 2 decades ago on lifestyle-related risk factors and risk of future nursing home admission. These people used a nice a 2-decade follow-up of a large data set and Cox proportional hazard model to analyze what were the risk factors associated with ending up in a nursing home for adults 45 to 74 years of age at baseline. Diabetes more than tripled the risk of admission. Smoking, inactivity, and elevated systolic blood pressure had risks of 1.6, 1.4, and 1.4 respectively. Conclusions: modifying lifestyles in middle age may reduce the risk of admission. If you're waiting for the clinical trial to prove this, you're going to be waiting a long time. It's not going to happen, unfortunately. There is some clinical trial data, though, that is supportive of the idea we can actually do something to stay out of nursing homes. And this is a Cochrane review of clinical trials looking at exercise to reduce the risk of falls. At least 1/3 of community dwelling people over 65 years of age will fall each year. I can attest to that. I fall at least once or twice a year walking to work on our slippery sidewalks, and I'm getting more and more strategic about how to stop that. If you look at the review of clinical trials that Cochrane did, exercise reduces the rate of falls by 23%. This was high quality evidence. Exercise may reduce fall-related fractures by 27%, and balanced functional resistance exercises probably reduce the rate of falls by 34%. So there is some evidence we can do something to prevent the need that we will end up having to be in a nursing home. I can tell you, having come off service just a couple of months ago, I'd say at any one time, we're looking at 25% of the patients who are on the medical floor who are there because they had a fall at home. And most of them are not going home anytime soon because we need to put the infrastructure in place to either help them stay at home safely or they need to go somewhere else. The fall is the, is the final straw that breaks the camel's back, if you will. Next slide, please. Learning objectives. Why calculate healthy brain age? And this goes back to really research that our group has been doing now since 1992. Next slide, please. The risk assessment landscape in 1992 looked encouraging. The lipid guidelines were rapidly evolving following the lipid research clinic trial results in 1984. The recently published Canadian Consensus Conference on Cholesterol Guidelines would have resulted in nearly half of adults requiring lipid meds. So there was an opportunity there to say, wait a minute, this doesn't make sense. The Framingham Heart Study risk equations were readily available to anyone who was interested, but they were largely ignored. It's interesting when you talk back in those days, when you talk to colleagues who were working in the Framingham Heart Study, they were apoplectic over the idea that hypertension guidelines, cholesterol guidelines weren't taking into account risk assessment, but they simply were not invited to be part of the conversation. And we recognized at the time that patient-centered risk assessment might identify those most likely to benefit from therapy better than just a cholesterol level or a blood pressure level. And it might be another way to engage physicians and patients to address treatable risk factors or unhealthy behaviors. These were the two studies that really sort of got our group going in this area. The first was, how well did the guidelines work? And this was back in 1995. We looked at the National Cholesterol Education Guidelines. We looked at the Canadian Consensus Conference Guidelines, and we said, how well do they work at identifying who's going to develop a cardiac event in the lipid research clinic follow-up cohort, which was a 15% random sample before the LRC study was done. And we used receiver operating characteristic curve or area under the curve analyses for this. And we showed that the Canadian Consensus Conference guidelines were the least accurate with an AUC of 0.7 or 70%. Remember, an AUC of 50% is basically non-informative. It's no better than the flip of a coin. The total cholesterol HDL ratio with an AUC of 0.72 was as accurate as the US National Cholesterol Education Program guidelines at the time. And if we took a coronary risk model approach using the Framingham data, you could have an AUC of 0.85. or 85%, which was vastly superior to the guidelines. And this was arguably one of the important moments when we finally got the lipid guideline committees to take a look at there had to be a better way than just treating cholesterol on the basis of what's your total cholesterol level. The other thing that happened a few years later is our group got beyond Framingham and started to develop our own cardiovascular risk models. And this was a publication where we presented for the first time the cardiovascular disease life expectancy model, where we showed that independent risk factors for cardiac death included cigarette smoking, sex, mean blood pressure, cardiovascular age, glucose intolerance, the log transformation of the LDL-HDL ratio. Most of those risk factors were risk factors for, I'm sorry, go back just one, Natty, if you can. Those were also risk factors for stroke death, and other causes of death were due to cigarette smoking, aging, and that was about it. The other important thing we did here in this graph below is we showed that you could use this modeling approach to predict what happened in randomized clinical trials. And the validation was a very important part of this whole exercise, showing that these equations really work. Now the next slide, please. Last but not least, if we wanted this sort of thing taken seriously, we had to prove that it made a difference in clinical practice. Now, fortunately, the bar wasn't held up so high that we had to prove that risk equations could actually reduce cardiovascular events, but we had to at least show that it would improve clinical treatment. And this was a randomized trial, the checkup study that we did across Canada to determine whether discussing a patient's coronary risk can improve the effectiveness of treating dyslipidemia. We had 230 physicians enroll over 3,000 patients and followed them for 12 months. And we saw significantly greater mean reductions in LDL levels and the total cholesterol to HDL ratio for those patients who received a risk profile every 3 months. We also showed that those who were provided their cardiovascular age were more likely to reach lipid targets, 26% more likely, and that there was a 6% and there was a significant dose response curve where the worse your cardiovascular age was, the more likely you were to reach lipid targets. It could even get up as high as 69% if you had a really terrible cardiovascular age. Now, you'd think on the base, next slide, please. You'd think on the basis of this, we would have felt like we were succeeding. But the fact of the matter is, it didn't work. Despite the guidelines, despite our clinical trials, despite proving that knowing your cardiovascular age made a difference, the vast majority of doctors were not prepared to do it. We should have recognized the signal in our early studies. They indicated they weren't crazy about cardiovascular age because it took a few more minutes with each patient, and we should have recognized that that was a major barrier. So we started putting this stuff up on the web, and we got some interesting promotion from both the Globe and Mail and Radio-Canada back in 2016 when we were trying to run this through community pharmacies. In a 2-week period, we had over 20,000 profiles completed. And this was the final nail in the coffin. We realized that the vast majority of Canadians couldn't assess their risk accurately because they didn't know their risk factors. 90% of Canadians didn't know what their blood pressure was or what their blood lipid levels were. So it was back to the drawing board. Next slide, please. So you may ask yourself, well, is there any health metric that might be engaging for Canadians and feasible without professional help, feasible to do without professional help? We were interested in dementia and Alzheimer's disease for a number of reasons. There was no effective treatment once symptoms appeared for a progressive disease. Risk factors had been identified, including several that were modifiable. There was a little bit of clinical trial evidence suggesting that prevention might work if one could identify who was at risk and which factors should be targeted. However, there were some very important critical challenges still. We had to make sure that whatever we built this time, people would know what their risk factors were and they could do their own assessments. It was clear there was no point in waiting for health professionals to do this. And last but not least, there had to be a strategy to engage adults to adhere to prevention, whether it was lifestyle or taking their medication for many years to come. And it was pretty obvious that risk assessment by itself just wasn't doing the trick. Let me give you a little background now. Next slide, please, on the dementia situation. This is the dementia strategy for Canada that just came out the past year. In the interest of time, I've got to make up a little. I'm not going to read you through the stats. Important point is the Canadian government recognizes we got a problem. Next slide, please. They've come up with 3 national objectives. Advance therapies and find a cure. Good luck on that. Improve the quality of life of people living with dementia and caregivers. It is possible, but it's going to take some serious resources and some serious support from the community, and I don't see that happening anytime soon. And prevent dementia. And they came up with a wide range of reasons, of ways to prevent dementia, including increase the contribution of social and built environments to healthy living and adoption of healthy living behaviors, which is just ridiculous without huge amounts of money. And the biggest problem I had with these was no mention about how to motivate Canadians to make the evidence-based behavioral changes, even if we did advance research to identify and assess modifiable risk factors and protective factors. But it was a start. At least they recognized that preventing dementia was important. This goes back, next slide, please. This goes back then to 2016. Here we are, trying to figure out how are we going to build a dementia risk model. And we really spent the next 3-4 years going through all kinds of data sets and trying this with Framingham, atherosclerosis risk and community study, Honolulu Heart Study. Nothing had the power we needed. In other words, the number of outcomes we needed and high quality data that we could pull this off until the UK Biobank became available. And this is where we were very fortunate that Healthy Brains for Healthy Lives a few years ago put together a consortium of researchers at McGill and used their budget to, get the Healthy Brains for Healthy Lives data, which, the UK Biobank data, which doesn't cost a lot of money anyways. It's only a few $1,000s. But the thing that made UK Biobank so fantastic was there were 500,000 participants, which is amazing, and 200,000 newly diagnosed cases of dementia during 12 years. And for any of you who do multivariate model building, what drives the analysis is not so much the total denominator, but how many cases do you have? And 2,000 cases is just, we hit the jackpot. The other thing that was so important about UK Biobank is it had all the fancy genetic and laboratory data, but it also had very carefully collected self-reported data. And remember, we were interested in a model that wasn't going to require imaging, genetic testing, fancy biometrics, being evaluated by a doctor, et cetera, et cetera. So UK Biobank had what we needed. We then used fine and gray subdistributional hazard models, which I don't have the time to tell you about, and Bayesian information criteria. And we compared that with various machine learning approaches, including lasso and Bayesian additive regression trees. I don't have time to tell you about those either. And this is the sort of result we got. If you take a look, these are the 4,000. I'm sorry, we had 4,000 cases of dementia, not 2,000. These are the 4,000 cases we have here: dementia present for women and men after 12 years of follow-up. As you'd imagine, people who develop dementia are older. They're less likely to be living in a household with a college degree. They're less likely to be employed. They're more likely to be lonely. They're less likely to attend a gym. More likely to smoking, more likely to have depression, diabetes. The list goes on. I can only show you one slide here in the interest of time. But the bottom line is, using multivariate regression techniques, we identified basically 14 to 16 independent risk factors for men and women individually, and that's how we built the model. The results of the model were better than we expected. Without using any biometric data, no cholesterol levels, no blood pressure levels, just self-reported diabetes, medical history. Basically, it was based on personal history, medical history, family history, and lifestyle habits. Our model had an excellent discriminating ability, or the area under the curve, of 84% for men and 85% for women. Good calibration. And it appeared that 50% of the risk may be due to attributable, modifiable risk factors. Now that's huge if it's true. You got to remember, just because we have a risk equation doesn't mean that that absolutely everything is truly modifiable to its full extent. And unfortunately, that study's probably not going to get done. But we at least had to see from a proof of concept pilot trial, was this something that would engage people to adopt healthy lifestyle habits? So we basically, and the other thing we had to do going forward was see if we could update the model to include more objective measurements, but only using wearables. In other words, would your smartphone or would a Fitbit or an Apple Watch provide us with more interesting information? I'm going to have to skip over that because I just don't have the time. Next slide, please. Let me show you what the partial attributable fraction is for these various risk factors. And the partial attributable fraction is defined as the fraction of all cases in a population attributable to a specific exposure. Weighted PAFs, calculated as the relative risk adjusted for potential confounders times the prevalence of exposure among cases, is how we calculate this. So for instance, if the relative risk of CVD among smokers is twofold, in other words, your risk goes up twofold because you're a smoker, but the prevalence of smoking is only 30%, the PAF is about 15%. You can see for men, not having an optimal self-report, in other words, having a health report where you don't say my health is excellent, has a PAF of 11%, loneliness 3%, not being a member of a gym or a sports club 9%, hypertension 4%, drinking tea, depression, stroke, previous MI. Put this all together and we can come up with about 49% of the attributable risk associated with developing dementia. For women, it's about 53%. Next slide, please. If you look at the validation of this, and we validate it on a separate data set from the one we built it on, you can see that this is the observed event rate by deciles of risk, and this is the predicted event rate. And this is the line of unity where the predicted and the observed match up. We're not doing badly. This is the top decile of risk. This is the lowest decile of risk. And this is everything in between. Calibration looks pretty good. It looked pretty good for white people. It also looked pretty good for non-white people, which I won't show you. Next slide, please. This is the fun part, the extrapolation part. Over a 10-year time horizon, dementia might be delayed by 2.5 years if the average individual achieved an optimal risk profile. In other words, if you take the average individual in the UK Biobank, the difference between this curve, which is the optimal curve, and this curve, which is the average curve, is about 2 to 2.5 years, depending on your age. Now, obviously, the younger you are when we get started, the bigger the impact should be. And that's particularly true if we go past the 10-year time horizon. These things are theoretically additive. So if we can modify your behavior at 41 to 50, we should be seeing the benefit that you see here, plus the benefit that you see at 51 to 60, plus the benefit that you see at 61 to 70. I'm sorry you can't see my pointer. I keep forgetting that, that I don't have control over the slides. I'm going to just quickly jump through a couple of slides because I'd like to leave a room for discussion. So let's finish off with what are the challenges and lessons learned associated with building and testing an effective program. Next slide, please. We learned these lessons from CHIP over 25 years. I'm sorry, go back one. I missed it. Sorry, go forward just one, Nadia. Perfect. If we learned one thing, it's the changing behavior is very challenging. The 2005 Canadian Healthy Living Strategy that was part of the launch of the Public Health Association of Canada came up with a 10-year objective of getting Canadians to eat more healthy food, like more fruits and vegetables, or increase the proportion of Canadians who exercised regularly, or increase the proportion of Canadians who had a normal body weight. After 10 years and spending up to $250 million a year, they didn't see an improvement, even a tiny improvement in a single metric. And I think Harvey Feinberg, who was the dean of the School of Public Health at Harvard, stated it very nicely. He said, there's real challenges in promoting healthy behavior. Statistical lives have little emotional effect. There's usually a long delay before rewards appear. Persistent behavior change is required, and most importantly, success is invisible. How do you engage someone continually by saying, well, the good news is nothing's happened yet? You can do that for a year or two, but how do you do it for a lifetime? Next slide, please. I'm just going to say that we then got in, as a result of CHIP and learning, that gamification, education, tracking, and building community were the reasons for success in an on-site health promotion program. We started to develop that into a digital health platform, one, to save money, because going to CHIP, even as a not-for-profit, was expensive. Even if the doctors were under Medicare, they still had to pay for the gym and for the kinesiologist. And this made it scalable and virtually, just about free if you could do it online. Now, I didn't believe it would be as good online as it was face-to-face, but it still had a lot of attraction. So back in 2014, we started testing this stuff out with the Department of National Defense, with the hospital, the MUHC, I should mention, and other various groups. And we started developing these various types of missions and watching our data. Next slide, please. And the one more, please. One more again. Thanks. You know, the model was based on eHealth, evaluate, engage, educate, encourage, and empower. And those are all really important. Evaluation is a way to, you know, come up with that teachable moment to get people started. Engaging them is the challenge. Educating them if you can, but one of the things we've learned is people don't read very much, no matter how we post it. Encouraging them, peer support is really great. And empowering them, reminding them that we can help them accomplish things that they've tried in the past and failed. And that's where the internet can be very, very interesting. Next page. I'm going to go past all the rest of how the program is designed and stuff. If you go down to, let's say, slide 36, please, Nadia. That's it. Over the last 10, 15 years, we've been able to prove to ourselves that we can increase physical activity substantially. We can improve sleep substantially. We can reduce stress substantially, and we can reduce the symptoms of depression substantially. We've published data, next slide, please, that shows that there's even a dose response. These were the results from the online wellness program from Merck Canada, which we did for 8 years before they finally let us go and decided they were going to do something with an American group. But bottom line here is, if you look up in that right-hand corner at those bars, the more you interacted with the program, the more your body mass went down, the more your waist circumference went down, the more your fatigue dropped, and the more your stress dropped. This is important because one of the problems with digital health stuff is there's rarely a control group. Very, very hard to talk a group of employees into agreeing they'll be the control group and get nothing. We occasionally get that opportunity, but it's rare. So we're always looking for ways we can convince ourselves the signal we're seeing is more than just a placebo effect and regression to the mean. And that's going to remain one of the big challenges. If you could move down to slide 39, please, and we're just about done. Setting up the healthy brain, go up one. Just one more. There we go. Setting up the HealthyBrainAge program was based on having a healthy brain age risk assessment, but now we needed to prove that we could engage people to do these healthy things. And we finally got a proof of concept trial funded by Innovative Solutions Canada, which occasionally comes out with these open competitions, but it's a great group to follow because the funding is substantial if you can get past the various barriers they put in. So we put together a team-based program that's currently being tested by a department in the Canadian government. It's a 24-week program with daily physical activity, Mediterranean diet, and Mood Booster. Mood Booster, by the way, is the same mission that any of you who just did the McGill Mood Booster mission, that's exactly the same one. The idea here is to support adherence with social connectivity, peer support, tracking, and gamification. I just want to show you some very preliminary results. Next slide, please. Yeah, from McGill. This was available just last night. As you know, the McGill Mood Booster mission just ended last week. We had over 600 participants in the McGill Mood Booster mission. Walking METs increased by 31%. Moderate physical activity METs by 8%, vigorous activity METs by 83%. That's huge. Vigorous METs may turn out to be really important in terms of reducing the risk of dementia. High stress levels dropped by 31%. Insomnia dropped by 29%. High depression scores by 20%. Loneliness by 10%. And high fatigue scores by 31%. At any rate, let me talk about the lessons learned to date, and I'll stop here. Last slide. The future for elder care is very worrisome now, and it's probably going to get much worse. Dr. Robert Salwa from our ex-commissioner and Harvey Feinberg were right. Measurement is critical, but may not be sufficient in isolation. It's a good place to start. It sets up teachable moments. It holds us accountable to whatever we're doing. But measurement's not enough. HealthyBrainAge might help engage and empower adults to make healthy lifestyle changes to prevent dementia, but it'll certainly never work without all kinds of other programs to engage, empower, build community, to support people in making these changes and keeping these changes going. And last but not least, I think the tsunami we're facing really underscores that compassion, empathy, measurement, accountability, and peer support are going to be critical in the next few decades. For the healthcare system, for sure. One of my disappointments in Bill 15 is I don't see any evidence that they've used measurement or an evaluation of previous metrics, comparing themselves to other provinces to come up with their new strategy moving forward, which means there's a good chance I believe it just isn't going to work. For our hospitals, we definitely need to be measuring at all times. Just off topic for a moment, if you look at our emergency room, we're right up there with the worst of Quebec, and there's an opportunity to fix that. For healthcare professionals, we need to look at what we're doing. And last, for the individual, if the individual's smart, they're going to recognize that the healthcare system is only going to take care of them so much, and they better get involved in trying to prevent this disease, because you don't want to end up in a nursing home. And I'll stop there. I'm sorry for all the technical stuff, but that's the way it goes.
You did it, Stephen. Thank you so much. Wonderful presentation. I will go right into questions because I see questions in the chat. Thank you for sharing this very important topic with us, Stephen. Sasha Bernaski comment about regarding changing behavior is a challenge. I think mental health issues are a big issue. I think this is why people, stop smoking, eating, going home. So the role, I guess, of mental health is being, what is the role of mental health in all of this, Stephen? Any comments on that?
As far as I'm concerned, mental health and physical health and overall wellness and happiness are tightly intertwined. And good examples of that are, we know that people who develop diabetes sleep less well. We know they're more stressed. We know they're more likely to have depression. We know if we get people to exercise or lead healthier lifestyles, we can treat all of those conditions and prevent diabetes. We know it's impossible to get someone to exercise if they're exhausted because they're not sleeping. They're all intertwined, and you really got to. One of the reasons exercise works so well is because it addresses both physical and mental health issues. But it's not a panacea. I don't believe in using exercise alone. I really do believe in using various techniques and approaches to deal with all those other issues as well.
Thank you, Stephen. There's a question here about the impact of tea and I guess overall diet on brain health. Are there really good foods and not so good foods, sort of antioxidants, teas, or any foods like that that might improve brain health?
If I had to guess, we did everything to get rid of tea. I was convinced this had to be a confounder. It came out of the blue. But it's interesting, drinking coffee turned out to be protective as well. It just wasn't as protective as tea. There's a part of me that thinks it could be the social moment, the relaxation, taking time for yourself. But I'll be honest with you, we have no idea. There is some data supporting tea. I'm not a big believer in specific miracle foods or miracle eating habits. I think the only data that's really strong is the Mediterranean diet, and that's that's an approach to eating as opposed to any one particular food. And we don't really completely understand why the Mediterranean diet works, but it's very clear the data is consistent. And not only does it work in preventing cardiovascular disease and diabetes, but there's also good data about it preventing cognitive decline as well.
Question, what is the longest follow-up you have on any of your missions? Are there improvements in lifestyle that do these persist with time?
Yeah, that's the most important question anybody could ask. The answer is we have data from Merck Canada that we can engage people for up to 8 years. And typically what we do is in a workplace setting, we, 2 or 3 times a year, we have a 6 to 8 week program, and then we let them start tracking and doing other things themselves. That to me, though, is not what's going to happen out in the real world. The workplace is special because people interact with each other, they see each other, they're accountable to each other. But going forward, the real question is going to be, what can we do long term in the community? And I really believe without some serious government funding, I don't see how we'll ever pull this off. And I personally don't believe the government funding is ever going to be there. So the best we can do is reach out to a small group of people who are interested, who are ready to make changes, and build a community to help them along and hope that it grows over time with as little funding as possible, because I don't know where it's going to come from.
Thank you, Stephen. Deborah, you unmuted yourself. We only have a couple of minutes left. And José Moret, I see that you've also put your hand up. Deborah, a couple of comments. We only have a couple of minutes, and then José.
I was just wondering, Stephen, if you can comment on the importance of gender stratified analyses.
Just set me up with something like that. There's no question that, first of all, Debbie knows much, much more about this than I could ever speak to. And all I can say is, yes, men and women are different. And I think trying to appreciate that in our analytic approaches and in our strategies is really, really important. We've given people the opportunity to only work with individuals of the same sex. It's interesting, the majority don't choose to do that. They seem to be happy to work with people of the opposite sex as well. But the analytics, I absolutely agree with you, Debbie. You've got to always be looking at men and women separately. They're not the same.
Thank you.
José Moret?
Yes, thank you, Stephen. I want to congratulate you for that enormous amount of work, but also very target. I think this is where the future lands on, is this need to have people embarking in habits that will help them age healthy. I just wanted to bring to your attention, and by the way, you do advocacy rule extremely well for aging healthy. But the decade to 2021, 2030, as proposed as decade of healthy aging by WHO, insists that along with individual control of risk factors, that cities, healthcare system need also to accommodate this growing number of older people. And you mentioned the problem during the COVID, ER, etc. But this is us that have certain attitudes that contributes to not target our care to the needs of that population. Our hospital milieu was constructed after the Second World War, where there was young, healthy people with acute problems. You deal with the acute problems, you send them home. Now is not the case. Many chronic diseases with physical impairment, and we have to show an understanding of this change in the presentation of illness and have the adequate resources that are missing. So thanks for all of this work and all the preventive aspects that you are proposing to us, because it's needed. Otherwise, you're going to all age with so much impairment that our lives will be miserable.
I can't agree with you more, Jose. You're absolutely on the money. And to be quite frank with you, even if we're not there personally just yet, our hospitals are jammed at the moment because of our inability to properly care for older individuals in our community. And I honestly believe that's only going to get worse. I just can't see how the numbers can go in any other direction.
Thank you.
Stephen, thank you. We're going to have to close the formal rounds. I invite you to please stay online so you can look at the chat. There's really great comments coming in. Obviously, it's a very well-received talk with all the comments. There's still some questions that are unanswered. Congratulations, not just obviously on the terrific presentation. I'm glad that we stuck it out despite the technical difficulty. And thanks everyone for your patience getting this presentation started today. But congratulations also really on your work and your advocacy in healthy aging, rehabilitation, physical activity, everything, everything that you've been doing over the last 20, 25 years at McGill, keeping, reminding us of the importance of this on a regular basis. So thank you so much. And please do continue to look at the charts, at the chat, Stephen, because there's comments and questions there for you. Thanks for your presentation. Thanks everyone for joining us. This concludes the official medical grand rounds presentation for today. Have a wonderful day.
And thanks for taking care of the slides, Nadia. Honest to goodness, I couldn't imagine it going worse at the wrong time. Take care. Be well.
It worked out, Stephen. It worked out. Thank you.
Alrighty. Bye-bye.
Hi, Stephen, are you still there?
Yeah, I'm still here. I'm looking at all the comments. Who is it?
It's Don here. I thought your presentation was really excellent, and thank you so much.
Yeah.
Really enjoyed it.
Thank you for saying that, but it really was it really was a disaster.
It was worth waiting for. Believe me. I was thinking of it's a bit precocious too. Like, I think this is really important work that we're going to find in the future, because we've been focusing so much on dementia prevention and treatment on like single disease processes, the amyloid process, and trying to target that with very little success. But to think of it more as dementia occurs in a much more complex way, and to address it by risk factors, and to look at multiple risk factors, and to do kind of like a multi-dimensional kind of prevention and treatment strategy, I think is a really novel, but perhaps maybe will end up being the most successful approach. And with that in mind, when you looked at risk factors, I see the breakdown of each thing individually, but if you combine them, did you notice that the risk goes up cumulatively or almost exponentially? And then also in terms of intervention, were people more successful if they did multiple things versus just one thing?
Yeah, those are really both excellent questions. On the first question, unfortunately, I poorly communicated it because I was going too fast. But in fact, all of those risk factors, the 14 to 16 risk factors for men and women, they are additive. So when I'm talking about optimizing your risk factors, I'm talking about optimizing all of them. But of course, we don't expect anybody to do that. One of the things, if you go to the HealthyBrainAge.com website, which I didn't have a chance to demo for anyone, you can try this yourself and you can see what the potential impact is for you, given your constellation of risk factors, what our best estimate is as to how much we can improve your healthy brain age by exercising more, not smoking, preventing diabetes, that sort of stuff. So they are additive. You're absolutely right. I'm sorry, the second question was... So
the next question was if in terms of the modifiable aspect of it, if you do more than one particular intervention.
No, it's absolutely multifactorial. And unfortunately, we can't prove definitively. We can tell you that the people whose mental health and biometrics improve the most are the people who do most of the things we recommend. And we're just analyzing the data for the McGill Mood Booster mission, which if I'd had time, I would have mentioned. We're going to be presenting the results to McGill faculty and staff on Thursday. But we're scrambling to sort of get through it all in time for a presentation. But I can't prove that doing it all reduces dementia. I can prove it reduces the risk of dementia, but of course, we don't know how good our risk models are until somebody comes up with a big dementia trial, and we can at least calibrate and validate our model on some real data. And that's what's missing in all of this. And the dementia story is going to be much tougher than diabetes or cardiovascular disease, in part because there's, at the moment, big pharma is just not there because the investment is overwhelming. And who's got the time to run a study for 12, 15 years to see how much you can prevent dementia? Well, if there's one thing that's clear, it's once you develop the symptoms, it's probably too late. So you got to get in there before people are symptomatic.
Yeah, absolutely. You're looking very long term and intervening earlier.
This is a project for big government, either the US or the UK. We'll never see any other jurisdiction, do this properly. And even though
it's an interesting parallel kind of research that Ken Rockwood has done in terms of the frailty index. And he had shown that with a higher frailty index, a significant increased risk of developing dementia. But that's kind of independent of the specific risk factors. So it's also looking at kind of multiple risk factors, but there the focus being kind of how much of them you have versus which ones specifically.
Yep. No, I absolutely agree with you.
Anyways, this is fantastic. I really enjoyed this, and I look forward to talking with you more about it.
Yeah, well, hopefully I'll be back on the wards in September. We'll have a chat. But you know how to reach me. I'm happy to talk to you anytime you want.